Test is now starting. All attendees are in listen-only mode.
Hello, everybody, and welcome to today's webinar, Addressing Social Determinants of Health via Medicaid Managed Care Contracts and Section 1115 Demonstrations. We are thrilled to be bringing you this content today and joined by presenters from the Association of Community Affiliated Plans and Center for Healthcare Strategies. We are very excited you all could join us and hope that you enjoy today's webinar. Next slide, please. My name is Alex Mays, and I'm the National Program Director at Healthy Schools Campaign, which is the organization that's co-hosting today's webinar with Trust for America's Health, our partners. I think just about everybody on this webinar is a member of the Healthy Students Promising Futures Learning Collaborative. But we are thrilled to have you join us. And just for those of you who might not be familiar with the Healthy Students Promising Futures Learning Collaborative, it's an effort that Healthy Schools Campaign and Trust for America's Health have been co-convening for the last few years now. And it's a multi-state effort to support states and school districts in expanding access to school health services through Medicaid reimbursement and really increasing access to safe and supportive school environments. Before we get started with today's webinar, I just wanted to review some logistics. Our webinar is going to run for about an hour, and we will be sure to make the recording of the webinar and slides from the webinar available later this week. We'll send out an email with a link to those so you can access them and share them. Also, at the end of the webinar, we'll have a very quick survey just to provide feedback on today's webinar, and we would really appreciate it if you could take a minute to complete that. We'll also save the end of the webinar for a question and answer session with today's speakers. So please, as you're thinking of questions throughout the webinar, don't hesitate to type them into the questions box on the control panel and hit send, and then we'll collect those and be sure to ask those of our speakers. Next slide, please. We also just want to thank the funders who are supporting the Healthy Students Promising Futures Learning Collaborative. They're listed here. We greatly appreciate their support, which enables us to bring programming like today's webinar to the Learning Collaborative. Next slide, please. So again, I said we are thrilled to be joined by three wonderful presenters today from the Association of Community Affiliated Plans and Center for Healthcare Strategies. I'll introduce them in a moment, but just wanted to say that, you know, certainly through the Learning Collaborative, we have continued to hear just that there's a tremendous interest from states and school districts in better understanding Medicaid managed care contracts and Section 1115 demonstrations, and really thinking about how they can work with partners and certainly managed care organizations to support the work happening in schools and address the social determinants of health. I do want to say, you know, ACAP and CHCS are going to be focusing in on findings from a report that they did at the end of last year, which really looks at how Medicaid managed care contracts and Section 1115 demonstrations are addressing social determinants of health. We recognize this research did not look specifically at schools, but just want to say that we still think it's incredibly relevant, since it really highlights, you know, how managed care companies and others are thinking about partnering with community-based organizations to address social determinants of health, of which there are certainly a tremendous amount of parallels for work with schools. And I also just want to thank ACAP and CHCS, since they have gone through and identified some really great specific examples of how Medicaid managed care contracts are addressing and working with schools and in the school health services space, which they will be sure to lift up. So before I hand it over to the speakers, I just wanted to quickly introduce them all. We are joined by Jennifer Babcock, who's the Vice President for Medicaid Policy and Director of Strategic Operations for the Association of Community Affiliated Plans, or ACAP. She also spent over 4 years as ACAP's Vice President of Exchanges. And in 2010, Jenny served as the eligibility and enrollment team within the Office of Health Insurance Exchanges in the Department of Health and Human Services, Office of Consumer Information and Insurance Oversight, where she focused primarily on the interplay between Medicaid and exchange coverage. And before taking on that role, she served as ACAP's Director of Policy, working primarily on Medicaid and CHIP health plan issues. Previously, she's worked on a wide range of policy related to Medicaid, CHIP, the uninsured, and private health insurance in the Office of Health Policy for the Assistant Secretary for Planning and Evaluation at HHS. She has a Master's of Public Health from the University of Michigan and a Bachelor of Arts in English from Kalamazoo College in Michigan. And then we're also joined by Jim Lloyd, who's a program officer at the Center for Healthcare Strategies. And in this role, he supports CHCS's efforts related to populations with complex medical and social needs and payment and delivery system reform, including the Transforming Complex Care Initiative and the Advancing Value in Medicaid MLTSS program. Prior to joining CHCS, Jim was a research associate at Rutgers University's Education and Employment Research Center, where he contributed to program evaluations and workforce training initiatives. Jim received his JD from Fordham University School of Law and a master's degree in public policy with a concentration in healthcare policy from the Edward G. Bluestein School of Planning and Public Policy at Rutgers. And then finally, we're joined by Diana Crumley, who's a program officer at Center for Healthcare Strategies. And in this role, she works on projects aimed at advancing primary care innovation, social determinants of health interventions, accountable care organizations, and value-based payment models. She provides technical assistance to states and providers, including through the Advancing Primary Care Innovation and Medicaid Managed Care Initiative, the Green and Healthy Home Initiative, reimbursement support for asthma programs with Comprehensive Environmental Health Services Technical Assistance Program, and the Medicaid Innovation Accelerator Program for value-based payment and financial simulations. Prior to joining CHCS, she served as a special counsel for the Health and Human Services Commission in Texas. And she holds a JD and a Master of Public Affairs from the University of Texas at Austin and received her bachelor's from Grinnell College. So we are thrilled to have these three fantastic presenters joining us today. I will now go ahead and hand it over to Diana, who is going to kick things off. Diana, do you want to take it away? And we can move on to the next slide, please.
Sounds good. Yeah, so we're here to talk about addressing social determinants of health via Medicaid managed care contracts and 1115 demonstrations. I am mindful that that is a mouthful. Our intended audience was those who read and write 300-page contracts and demonstrations. So I approach this presentation with some humility and also want to make sure that we're exposing you to important terminology. In this field, we often see our role as primarily one of translators, so we really want to make sure that you're exposed to terminology and are able to engage in conversations with managed care organizations in this way. Next slide. So as I noted, we're going to start off with a Medicaid 101. Then we'll go and have an ACAP summary of plan activities in schools. Then we'll talk a little bit about our report and findings. We'll probably won't go into detail as much as we did on the original webinar, but enough to give you some exposure. And then we'll have some key takeaways and recommendations. And throughout this presentation, we want to keep in mind that schools can be providers and also community-based partners. And they can help healthcare organizations, including managed care organizations, engage members and their families and ease access to services, including those outside the realm of healthcare. Next slide. So what do we mean by social determinants of health? And in a lot of ways, this is very intuitive, especially for the education crowd. Things like zip code, housing stability, are definitely social determinants of education, and that's certainly the case for healthcare as well. So very broadly, the social determinants of health are the conditions and environments in which people are born, live, learn, work, and play. And they also have a marked impact on individuals' health, and often larger than that of medical care. This little pie chart on the right, you often see varying versions of this. But what is consistent is that healthcare is attributable to a very small percentage of outcomes. And it's really the things that happen outside of the physician's office that really affect healthcare outcomes. So up to 60% when combined with behavioral patterns are due to things outside of healthcare and related to the social determinants of health. Increasingly, we are seeing payment models in which healthcare organizations are somewhat responsible for an attributed population. So now there's a business case. Accountable care organizations, managed care organizations often are assigned a population, and they are now responsible for keeping that population healthy, to control costs and provide better care, and provide quality care. So addressing the social determinants of health or social needs at the individual level is undoubtedly a way to provide better, more efficient care. Next slide. And here are some examples of what we mean when we discuss social determinants of health. You'll see that education is squarely at the center of that, but you also might notice that schools as important community partners are often aware of many things within this chart. They are responsible for food. They are important members of a community and are aware of struggles within a neighborhood, as well as physical environment like parks and playgrounds. So they touch children's lives in a much more consistent way than healthcare and can contribute greatly to the overall health of a child. Next slide. So here's a little bit of Medicaid 101. I'll start broad, and then Jim will take it over with a much more granular overview of our findings. Next slide. So Medicaid is a federal-state partnership. Here at CHCS, we often refer to it as a marriage and a marriage with tension. There's a push-pull of federalism and states' rights since the start of the U.S. government. Medicaid is a federal-state program. The federal government pays half the national cost of Medicaid, and so that means some serious influence over the program. Some states have a strained relationship with Medicaid. You may be familiar that it's a sizable portion of the budget. In addition to education, it's probably close to 70% of the budget when combined. So there's often this subtext of it being a strained relationship, or perhaps a relationship that you want some flexibility in. Next slide. So these are the two types of flexibility that you often see in state Medicaid programs. You have the state plan, and the state plan essentially has a very long list of different services that can be covered within the Social Security Act descriptions. So essentially the state will say that it will cover XYZ service and reimburse it in a certain way. And then you have waivers. And there are many different types of waivers. 1115 demonstrations are one type of waiver, and they're the broadest type of waiver. You often hear about delivery system reform demonstrations, and those often have a big chunk of money that can be invested in a variety of good things. Next slide. And next we have Medicaid managed care organizations. So states enter into contracts with MCOs to manage medical risk, the uncertainty inherent in future medical costs. Federal rules outline broad parameters of Medicaid managed care programs. So essentially states in your contract, you must have these provisions. MCOs have to provide care coordination services, to clearly state what services they're going to cover. And the vast majority of states have Medicaid managed care programs. Now, that's not for all populations, and it's not for all regions, for example. But most states have some version in their states, some version of covered populations, and some understanding of what services exactly the managed care organization is going to cover. Next slide. So 39 states, including DC, contract with MCOs. And in November, that North Carolina shape right there is going to turn blue. And Arkansas, as of March now, has something that kind of looks like an MCO called a PASS. And they're going to be contracting with that organization on a full risk basis for a limited population. So by and large, it's a very dominant delivery system model. And this is the trend across the United States by and large. Next slide. So what does that look like? So usually under fee-for-service, the agency directly pays the provider. Under managed care, the agency pays a per member per month rate, a capitation rate, and then the plan goes out and pays providers based on submitted claims. The plan also performs care coordination functions and otherwise takes care of that population, given that they're only paid a certain amount of money. And so they have an incentive to take better care and provide more coordinated care to beneficiaries. Next slide. Next, I'm going to turn it over to Jenny Babcock, and she's going to give some examples of what that looks like on the ground.
Sure, thank you, Diana. This is Jenny Babcock. I work for the Association for Community Affiliated Plans, and very, very briefly, ACAP is in Washington, D.C., and we represent 60 what we call safety net health plans or Medicaid managed care organizations that are not-for-profit and focused primarily on Medicaid and CHIP, so publicly subsidized healthcare for low-income people. Our plans do also operate in the Medicare world, and also some of them offer qualified health plans in the marketplaces for the purpose of furthering their mission of providing high-quality healthcare coverage to people who are in government-run healthcare programs. So we do operate in 29 states across the country. So we're in a lot of the parts of the country where there is fully capitated Medicaid managed care. And some of our health plans are fairly new and small, but many of them have been around for upwards of 3.5 decades. And so they have really built some sophistication around how to, A, provide good quality healthcare coverage for people, but also around partnerships in their communities, including with schools and school districts. And I'm just going, I have so much to tell you, but for this purpose, for this webinar, I'm going to focus on just the next couple of slides, whereby I'll provide a couple of examples of how our health plan members are working with school districts or school-based health clinics. And so just so that you know, we query our plans every so often about the work that they are doing with schools. And the examples I'm going to share with you right now are derived from these questions, these mini surveys we've done with our plans over the past 2 to 5 years. So some things might have changed in these states, but very briefly, we did have a health plan in Colorado tell us that it has very securely incorporated school-based health centers as one component in its broader provider network. In Indiana, we have a fairly large Medicaid MCO that is owned by provider entities, by hospital systems. that works with a very broad and well-organized school-based health clinic that touches over 100 schools in a very large urban area, probably Indianapolis, although they didn't specify. In Minnesota, we represent a public health plan, so a plan that is owned by the county government, Hennepin County, that no longer, at the point of this survey, that no longer covered children, but in the past had contracted with several school-based clinics. And what I liked about this particular answer was this health plan it sort of enjoyed expressing that it found great value in those relationships with school-based clinics by way of increasing EPSDT and lead screening rates for the children that were served by those school-based health clinics, and also in an increase in preventive dental referrals. And so this, of course, these improvements in quality are very meaningful for the health plan, certainly, but also for the population that it serves, which is the ultimate goal. In Rhode Island, we found that an MCO member works with school-based clinics, but contracts with the community health centers in its state, which then ensure that the school-based clinics are part of the network. In Texas, we found that 2 of our health plans were willing to tell us about their relationships with the schools, and one of those MCOs contracted with a broad health network, which includes school-based health clinics. And this one also provided some color around that relationship as well by saying that there were some challenges with the school-based clinics in its network related specifically to staff qualifications, to scope of services that were provided, and also to limited operating hours, which are probably not uncommon, and certainly challenges in provider networking are not restricted to school-based clinics. This is something that our plans work on all the time with their broader networks. The last bullet point here, another Texas MCO said that it didn't contract directly with school-based health clinics, but did develop partnerships with them like they would with community-based organizations in order to identify the children of migrant farm workers who were in need of healthcare services for the purpose of increasing access to healthcare. Next slide, please. So in addition to this specific work or contracting or subcontracting with school-based health clinics, a couple of our health plan members also mentioned that they built other sorts of partnerships that weren't related to a direct provider network arrangement. In Indiana, that same fairly large MCO made it clear that they were interested in making donations to school-based health clinics and schools in their community, and were frequently engaged in looking for additional ways to reach families and children for a number of different purposes. And then in New Jersey, an MCO member of ours mentioned that it worked on several different public health initiatives, community-based initiatives with its schools, with the schools in its state, including anti-bullying campaigns and obesity and nutrition programs, fitness challenges, and also provider development and health education, provider education for school nurses. So there are broad examples of arrangements between the schools and the health plans, and I very much appreciated this opportunity to look into what our plans are doing. It gives me food for thought about future research and work that ACAP should do. So with that, I'm going to turn it over to Jim, I believe.
Thank you, Jenny. Next slide, please. Yeah, I'm going to do an overview of the findings from our report and talk a little bit about some examples and potential opportunities for MCOs involved in Medicaid to work with school health. Next slide, please. So about the report, our report focused on requirements and incentives that states created for managed care organizations to address beneficiary social determinants of health. We reviewed 25 Medicaid waiver demonstrations and 40 model MCO contracts. Notably, we did not look at the individual relationships between plans and providers that exist in states, though Jenny just provided some very helpful examples on that. Nor did we look at the relationships between MCOs and schools specifically. But we think the work's still relevant. There are a lot of parallels between school districts and the community service providers that were mentioned in the contracts and waivers. And many support opportunities are what we call provider agnostic, meaning that the regulations do not specify exactly what types of organizations MCOs are permitted to engage to fulfill those requirements. Next slide. So some key findings from the review of MCO contracts. Taken as a whole, our research showed growing attention on SDOH within states, with new state MCO reprocurements focusing on incorporating social determinants of health. The most common area in contracts where states included requirements was the care coordination and management sections, which permit MCOs to contract with outside organizations to help better care for their beneficiaries. Additionally, the contracts included little detail for the requirements, which actually grants the MCOs more flexibility and could potentially provide an opportunity for working with school health. Next slide, please. The waiver demonstrations we reviewed focused on enhancing care coordination and building community partnerships. And here we saw more payment incentives to advance those efforts. Healthy behavior incentives were not typically linked to social determinants of health, but two states, Indiana and Arkansas, who had work and community engagement requirements, also provided services to beneficiaries to help them meet those requirements. Next slide. So now I'll start to go through some of the examples that we came across in our review, with these systems and partnerships focusing on care coordination and the quality assessment and performance improvement terms. Next slide. Here is the first of many maps I will go through in my slides of the 35 states that use care coordination terms in either their 1115 demonstrations or model MCO contracts. So I won't go through in detail each of these maps that we get to, but they're all in there and you can review them later at your leisure. Next slide, please. Here we get into some of the details of the regulatory requirements. The care coordination and management terms require the MCOs screen beneficiaries for risk, and states often included SDOH-related language in those sections, either through requiring initial screening for SDOH or in later comprehensive health risk assessments for individuals with special health care needs. And since MCOs are tasked with managing the medical risk of their beneficiaries, the contract terms sometimes included directives to stratify their populations by risk, including potentially risk related to SDOH. In addition to screening, the regulations require linkages to needed resources where MCOs can coordinate with community and social support providers. These linkage terms include referrals to those services, requesting that they close the loop, which establishes a line of communication between the referring organization and the service provider. Notably, these linkages and screening could potentially be an opportunity for school districts to work with the MCOs for their beneficiaries, since the community and social support providers can include school health, and schools are a universal place where virtually all members of a community have some interaction with through their children. Next slide, please. So here are two examples of care coordination terms. Kansas's MCO contract is full of references to social determinants of health and requires screening, and also requires the MCO to maintain community service coordinators to ensure the linkages to resources to meet the beneficiary's needs. Similarly, North Carolina's 1115 demonstration creates a program called Opportunities for Health, which provides care coordination through lead pilot entities, which are then tasked with contracting with various community providers. So both of these options create an entity that is then well placed to coordinate beneficiaries' receipt of social services, and that could be an entry point for a school district or school health that wants to engage with the MCO, and that could then in turn benefit the MCO through helping their beneficiaries. Next slide, please. Here's a map of the 14 states that include social determinants of health in their quality assessment and performance improvement terms. Next slide, please. So to avoid saying that over and over again, we began to call the quality assessment and performance improvement terms QAPI for QAPI. And so if you hear me say that, that's what I mean. Under the federal regulations, plans are required to establish QAPI programs that include the development of performance improvement projects, smaller pilot programs that focus on certain topics to improve plan performance, and have to create results that can be formally evaluated. These can be ordinary sort of quality improvement programs such as improving the processes for reviewing claims or any other work that the MCO might do. But states can also require that the cooperative projects include efforts to address specific topics, including potentially beneficiary social determinants of health. Next slide, please. So, for example, in California, the state contract requires that MCOs propose performance improvement projects that address health disparities among beneficiaries. Similarly, the District of Columbia's MCO contract requires that its contracted MCOs propose performance improvement projects that identify the disparities and other social determinants of health, along with the causes of those disparities, and then create detailed plans of action to address them as part of the QAPI efforts. So depending on how an MCO wants to develop its performance improvement projects, this could be another opportunity, another entry point for school districts that are interested in addressing, in partnering with MCOs to address their students and the MCO's beneficiaries' social determinants of health. Next slide, please. So here I'll talk a little bit about some examples of innovative healthcare payment models that are used in waiver demonstrations and managed care contracting to support investment in social determinants of health. Next slide, please. Here's another lovely map with 24 states that offer what we characterize as additional services to provide SDOH-related services to their beneficiaries. Next slide, please. So when we talk about additional services, it's really tied to how MCOs are paid in Medicaid. Typically, providers are paid if the individual is enrolled, the service is covered, the provider is enrolled in Medicaid, and the service is medically necessary. But there are several options in the following slides for MCOs that allow for more flexibility in what they pay for and in what types of services they can provide to their beneficiaries. Next slide, please. There are two major categories of services that go beyond the traditional Medicaid services. They're known as value-added services and in lieu of services. The former category, value-added services, can be any service that improves healthcare quality. So there's a tremendous amount of flexibility for MCOs to pay for various things that could support and improve their beneficiaries' health, but the costs are not factored into subsequent years' payment rates. So if the MCO makes an investment in value-added services one year, that money may not be in the budget the next. In lieu of services, on the other hand, do factor into subsequent years' payment rates and therefore subsequent budgets, but they have to fulfill certain requirements, that the services are medically appropriate and cost-effective, and that they're identified and authorized in the contract. So where you have flexibility in terms of what's in the contract, there's less day-to-day and case-by-case flexibility with respect to the in lieu of service funding. Next slide, please. Texas's contract and Massachusetts's 1115 demonstration waiver are two examples of how states are using the flexibility allowed by these payment models to support more investment to address the social determinants of health needs of their beneficiaries. Next slide, please. We do not find many states that use direct payment incentives to encourage their MCOs to invest in social determinants, but these four do. Next slide, please. So states can set targets in certain areas to create incentives for plans to invest in social determinants, whether it's receiving extra money through an incentive arrangement, earning back a pot of money that was withheld at the beginning of the contract year, or through the imposition of a penalty to the MCO's payment rate. These payment incentives are a potential lever for organizations that can effectively address social determinants of health to engage with MCOs and work with them. And so if an MCO decides that it can improve health through working with a school health organization or a school district, these are again, another entry point where the district could potentially engage with an MCO to partner to improve the lives of their students. Next slide, please. One example that we have for this is Michigan's managed care contract. There's a pay-for-performance bonus for the MCOs if they effectively implement programs to address population health, low birth weight, and emergency room utilization. This program also has an evaluation component, so the MCO has to report back on the intervention and compare results with a baseline. That's another thing that we saw a lot of, and really a direction that the federal government is going in terms of when it does provide additional flexibilities and the types of additional programs that it does support. The idea that you could look back at it and try to develop an evidence base for these types of interventions is very important in their decision making. The next slide, please. Here's a map of states that use what we call value-based payment programs, known as VBP. Federal regulations permit MCOs to engage in value-based payment arrangements, and then through that, they have additional flexibility to address social determinants of health as part of those arrangements. They're designed to align the incentives of payers, providers, and beneficiaries, and they're very, very complicated and not worth me spending any more time trying to describe here. Next slide, please. So we have two examples here. In New Mexico, managed care organizations can delegate part of their care coordination responsibilities to other organizations, provided those organizations are part of a VBP payment arrangement with the MCO. And within Rhode Island's demonstration waiver, organizations participating in their Accountable Entities program receive incentive funds to develop capacity to address social determinants of health. And they have requirements to work with social service providers to deliver the services. Next slide, please. So we have a few key takeaways and recommendations that we think might be applicable to your work back where you are. Next slide, please. So one of the themes I'm sure I've repeated endlessly this afternoon is that MCO contracts have flexibility to work with other organizations to provide services to beneficiaries. There's no reason why MCOs couldn't work with school health to coordinate care for beneficiaries, and there are opportunities to receive payment for supportive services. Additionally, and this is also critical, MCOs are all different. As Jenny described earlier, there are lots of examples of MCOs that are working with school health in, innumerable innovative ways. And so the lack of specific mention of school health in either a contract or a waiver demonstration or a formal program description doesn't necessarily mean that there's no possibility of cooperation. There may very well be with those MCOs, but again, it's something that our paper did not look at. Next slide, please. With respect to authority and funding, states can create incentives through a variety of funding mechanisms, primarily aimed at improving beneficiaries' health more cost efficiently. So if there are ways to do that through partnership with school health, those arrangements can certainly fit within the various funding approaches that we described. I think the issue is that a lot of these funding approaches, are described very technically, and they are really aimed at the managed care organizations and sophisticated healthcare providers. And so other organizations might not necessarily recognize the opportunities to play a role in them. For example, few of the Section 1115 waivers so far have included engagement with school health. Again, formal inclusion in a waiver doesn't foreclose the possibility of partnership between, a state Medicaid agency or an MCO and a school district or school health, but we did not see any examples of inclusion of school health at the level of the 1115 waiver demonstration. But that's not to say that, again, the work can't be done, or future 1115 waiver demonstrations or future managed care contract reprocurements could not engage school health and school districts. Next slide. So, visit chcs.org. Basically, this is the turnover to the Q&A. If you want to take control back and get set up for that, we appreciate it. Thank you for listening to us.
Great. Thank you so much, Jenny, Jim, and Diana. We really appreciate you sharing such wonderful content and really lifting up the opportunities for partnerships around supporting school health. So thank you for that great content. So for participants listening in, please feel free to keep sending in questions through that chat box. I know there was a lot of great content included in the slides, and we will certainly be sending, again, we'll send that link out so people can download the slides and you can take a closer look at all those great maps to get a better sense of what's specifically happening in your state if you missed anything. So I'll go ahead and get started with the first question, which is, I think, could be answered by any or all of the speakers. So for participants on the webinar who are less familiar with these state policy levers, could you give us a sense of how easy or hard it is to move them through at the state level? Are there key pieces that need to be in place in advance? And what's the general sense of the timeline for moving some of these opportunities?
Yes, so 1115 demonstrations, they can be relatively narrow or relatively broad. Things like delivery system reform demonstrations are kind of monster documents that require a lot of stakeholdering and public notice. So they have a longer timeline. For relatively narrow 1115 demonstrations, that timeline perhaps can be truncated a bit. For contracts, certainly there's a procurement cycle, and often, and this speaks to some of the incentives for managed care organizations, often in that procurement, states will ask about planned social determinants of health strategies. So often, MCOs have not only current contract requirements relating to this work, but also kind of a long-term strategy for really developing community partnerships in this area so they can point to successful pilot programs in the future in future procurements. And then on top of those procurements, which are often, again, a big undertaking for states, there's contract amendments, and those happen with some regularity. It depends on the state, either yearly or every 6 months.
Great, thank you so much for that. That is very helpful additional information. And just, so for the next question, and it would be, where could I find out more about what's happening in my state around addressing social determinants of health through Medicaid managed care contracts and MCOs more broadly?
That depends. If there's a managed care organization in your area that serves your region, sometimes the best approach, and Jenny could probably speak to this, is to go to the MCO and see what is available. Many MCOs now have an official social determinants of health employee, sometimes someone at the vice president level. So those sorts of employees might be good for a specific outreach. And then your state Medicaid agencies are certainly a resource here. There's a variety of different road shows and things like that that state Medicaid agencies sometimes throw for furthering some of these initiatives. But Jenny, perhaps you have some on-the-ground insights on how to engage your local MCO?
Yeah, it's a great question and a very welcome one. Let me give you a very specific example. We represent a couple of health plans in Texas, as I've described previously. One in Harris County in the Houston area has made a very explicit effort to build a staff and a program around social determinants of health broadly, but to begin, they're piloting an educational program that very specifically targets kids from a particular high school and pregnant women. So they'll take on a number of these high school students and a number of pregnant women with the purpose of developing their educational attainment and then paying for their community college work. So this health plan has made a very clear effort by way of hiring senior level staff, as Diana mentioned, and doing outreach to area schools for the purpose of building this relationship to recruit students to this educational program. And it is true that many of the Medicaid MCOs that ACAP works with, but also I think in the for-profit world, to be honest, that are developing this sort of staff capacity to to make connections with community-based organizations and with schools and other entities for the purpose of developing this work. And I do have to say too, though, as you've clearly seen from Jim's and Diana's presentations about how the states themselves are approaching social determinants of health, the same is true for Medicaid health plans across the country. I have spent the better part of 3 or 4 years trying to figure out what the themes are with regard to state or health plan social determinants of health work, the interventions that they're building. And while there are themes, they focus on employment or educational attainment, or certainly housing or nutrition and obesity prevention, social isolation, things like that. Each are doing this work in a very, very individualized way. They are responding, each health plan that I have seen that is doing this sort of work, and by the way, nationally, over 90% of all Medicaid MCOs are doing some sort of work related to social determinants of health. But each of them, in my view, with my bird's eye view, is sort of doing it in a way that responds very specifically to the needs that the staff, that the people at the health plan are seeing exist in that community. So the plans that we serve in Texas are doing one thing, and the plans that we serve in Ohio are doing something quite different, and then in Pennsylvania, again, something different, and then in California, again, something different, and in Oregon, and so on and so forth. And some of them are doing this work in response to the waiver, the demonstration, as Diana and Jim described, or to the Medicaid managed care contract, or some of them are doing it quite organically. They're doing it without any impetus, any requirement or incentive from the state, but because they see a need and they use their reserves, or our plans are not for profit, but their so-called profit to invest in that work. So I hope that helps.
That's incredibly helpful. Thank you so much. And some great examples you lifted up as well, which is always very appreciated and helpful. Great. Next question is, if we want to learn more about social determinants of health screening questions and what that looks like at the local level, where could we find more information about that?
This is Jim from CHS. That's a really good question. In terms of the efforts being undertaken by managed care organizations in a particular region, I think the best option is probably, as Diana described, to just call up the MCO, find out who their provider relations people are, if they have SDOH-focused office, reach out to them. They're certainly going to want to be involved in more social determinants of health screening. We have a number of resources at chcs.org on social determinants of health screening as such. A lot of the organizations that we work with are interested in doing so and in doing so effectively. And so I think if you search, social determinants screening on CHCS, you'd find, webinars and issue briefs. But they're really about sort of what kind of questions you ask and what type of instruments to use. But those will also probably be the questions of the instruments that an MCO might be interested in. But to the extent a school district or school health wanted to get involved in that, I think just directly engaging the MCO, because since school districts have virtually everyone in an area, depending on the population there, that would be something the MCO would be interested in.
MCOs are often obligated, within a certain number of days to screen all their beneficiaries, and sometimes populations or certain beneficiaries are very hard to get a hold of. And so school districts would potentially play into an organized strategy to get that screening done in some capacity.
And at ACAP, we have written a number, we're just finalizing the third in a series of what we call fact sheets, shorter papers on what our health plans are doing in a couple of areas of social determinants of health. We've looked at transitional housing for long-term care patients. We've looked at efforts to address chronic homelessness, and very soon we'll be publishing something related to educational and employment supports. And we have asked our health plans, as we've developed these case studies on their work in these areas, how do you identify your populations, your target population? And it is quite varied. In some cases, the plans will receive data from a county government or state government, for example, on homelessness. In some cases, they will use a screening tool of the sort that Jen and Diana just sort of described. In some cases, they get assist from their providers. But there, I think, is an increasingly sophisticated screening process that many plans and providers are using to get at that very question. So what are the needs of this individual that go above and beyond access to a primary care physician or other type of health service that will help steer the plan to address the person's social determinants of health needs.
Great, thank you all for that additional information, those thoughtful responses. Next question is specific, so it's absolutely fine if you don't know the answer to this question, but wanted to put it out there. Are any state Medicaid agencies allowing MCOs to provide transportation to places other than medical appointments if it will improve health? So for example, transportation to the store to shop for WIC, or it could also be your MCOs and schools partnering to support opportunities for healthy foods for families. So you're aware of any partnerships or that are happening around transportation, or specifically calling out that MCOs can support that activity?
So this is Diana. Certainly, MCOs can provide some of those transportation services as value-added services. Of course, non-emergency medical transportation is covered by Medicaid in most states, and there's an increasing trend to request a waiver of that sort of service. That certainly can happen. In addition, North Carolina has a specific 1115 demonstration provision relating to transportation to social services, so that's going to be a component of their pilot program. And Jenny, maybe you have some additional examples.
I'm just racking my brain to think of specific examples, and I can't at the moment, but the plans, as Diana just mentioned, they have some flexibility as they build a profit or reserves. If they have extra funding in their capitation rate, they can use it quite flexibly. And I believe that some of our plans are using some of those dollars to provide transportation, for example, to a GED program or to employment support program. So whoever asked the question, I think our contact information might be in these slides. You can feel free to reach out later, and I can look into that a little bit more carefully.
Great, thank you so much. We really appreciate that offer, and that was great information to share too in response to that. Next question, you lifted up some great examples of connections between MCOs and schools. Do you have any thoughts on best practices on information sharing between schools and MCOs to support coordinated care and reduce duplication of services? This is something in particular that has increasing importance just around mental health service delivery. But just wondering if there are any thoughts that you could share around best practices in terms to coordinate care and share information between MCOs and schools.
This is Jenny, and I very, very firmly wish I had a good answer to that. I don't myself. I think that there might be some evidence, some work and research regarding best practices between community-based organizations and plans somewhere. The duplication of services question is really key, and we've heard that. I haven't heard that specifically from school-based providers, but have been in conversations with other providers, primary care providers, and other groups in the past who are concerned about, for example, duplication of care coordination services. And in some programs, if an individual is enrolled in a particular program and they have a good physician, home-based physician, and they have a great MCO, there are occasionally problems with duplication of that care coordination effort. So I'm just corroborating your sense that there can be an issue, and do not know specifically if there are best practices around communication. Maybe Diana and Jim know better.
That sounds like a topic of a future CHCS brief, but
We would love that.
Great idea.
Certainly would love to learn from this collaborative to the extent that you've worked on something that you view as successful.
Yeah. We, Diana and I are both former attorneys, and when the question asker described sharing data between MCOs and school districts, our eyes went really wide, and we just thought, wow, that's going to be a long contract, isn't it? Very complicated question, but an interesting one and a good one to ask. Thank you.
Yes, no, and thank you for thinking it through too. And we would certainly love to follow up if there's opportunity to dig in more to that. Great. So one last question before we wrap up from a participant just wanting to know if you have any advice for a strategic approach to engage reluctant or risk-averse state health or education agencies in this work.
This is Jim. I think in terms of, addressing or engaging with folks who are risk averse, I think bringing some evidence when you show up, like some evidence of impact, some, effort to show the value of the work that you plan to do, whether it's an existing case study, existing studies on that type of intervention, a past track record of success for the intervention that you've already had, whether it's with another payer, or just paid through out of the school budget. The real focus coming out from Washington is on that evaluability and developing an evidence base. And when it comes down to it, MCOs are involved in managing the financial risk. And so if you can show that there is a, value to the work that you're doing, I think they're going to be more likely to listen and sit down at the table with you about it. So I think, having some evidence and having a way to show the value of the work you propose to do, having it at the beginning would be valuable.
Those are great insights, and really to the extent, and that we hope that we helped you learn about the relevant terminology that managed care organizations will be familiar with. To the extent that you can speak their language and say, hey, we know that you're probably thinking about a social determinants of health strategy. You're thinking about better ways to provide care, value-based payment. You can kind of feed into their lingo and impress them that way, perhaps.
That's great advice. Thank you so much for sharing your thoughts and insights on that question. We really appreciate it. So I know we are at the end of our time, but I just wanted to say thank you so much again to Jenny, Diana, and Jim for your time. We greatly appreciate your insights and taking the time to share this wonderful content with this group. We look forward to being in touch. And if this webinar sparked additional questions that you didn't have a chance to answer or ask on the webinar, please don't hesitate to send them, and we will make sure they get passed along to our presenters. So thank you, everybody, and thank you to the participants for joining today. We'll send out a recording and slides from the webinar later this week, and hope everybody enjoys the rest of their afternoon.
Thank you very much.